Hi everyone, in this video we're going to review the checklist for fibrinolytic therapy for STEMI patients. Now some of you are probably thinking, why are we looking at giving clot-busting drugs for AMI, for a STEMI, when usually we could just send them to the Cath Lab? Typically we reserve fibrinolytics for embolic strokes. Agreed. Well, the world and the universe has a way of making old new again. Yesterday, a friend of mine, my pediatric guru, Scott DeBoer, called me and he said, hey, you got to log on to this webinar. And it was the 5th annual Cardiology conference from the University of Maryland. And interestingly enough, toward the end, they had a COVID update for cardiologists. They took a small sample survey, and what they found is that right now, more cardiologists are treating AMI with fibrinolytic therapy than they are sending the patient to the Cath Lab, for all the obvious reasons. So, staying up to date on some of these older procedures or older therapies that we normally wouldn't use because we have something better, we got to stay on top of this because you never know when old is going to become new again. I was lecturing yesterday on abdominal trauma, and to my paramedic class I told them before we had fast scans for the abdomen in the ER, we used to do diagnostic peritoneal lavages. Look that up. I still remember how to set up for a DPL because you never know what's going to happen. Okay, first up on our checklist, hypertension. Now, hypertension is kind of a relative contraindication because we can administer medications to lower the blood pressure. And they're kind of using a systolic between 180-200 and a diastolic of 100 to 110. I just look at the bottom numbers. So if the blood pressure is 180 over 100, we want to treat that hypertension before we administer fibrinolytics. Next, we want to look at the difference in blood pressure between the right arm and the left arm and see, is there a difference greater than 15 millimeters of mercury? Now, what we're really looking for is a dissecting aorta. Now, looking at the aortic arch, the first vessel that branches off of that on the right is the right brachiocephalic artery. As the dissection is occurring, it's bulging that vessel out, and that bulge can partially occlude the opening to that artery, which is going to reduce the pressure in that arm. Now, some of you may be thinking, yeah, but there's a difference in symptoms between a dissecting aorta and an AMI, or a STEMI. Not always, and especially in the elderly, where symptoms can be very, very vague. Anytime you have a patient with vague symptoms, STEMI, get a pressure on both arms, try to detect a dissecting aortic aneurysm. Because if we administer fibrinolytic therapy to a dissecting aorta, it has a pretty predictable outcome. Next, any structural central nervous system lesion, brain tumor. If they've ever had a history of that, they are not a candidate for fibrinolytic therapy. Next, has the patient suffered any head trauma in the last 3 months? Of course, this is subjective. You're going to really have to inquire what kind of trauma did the patient suffer. Was this a major trauma? Were they hospitalized for it? Or did they just bonk their head at home? So this is subjective and warrants further review prior to administering TPA to a patient. Next, a stroke, greater than 3 hours but less than 3 months. It'd be kind of interesting if the patient presented with symptoms of AMI and embolic stroke at the same time, were a candidate, got the TPA, resolved both issues, then the question becomes, can you bill for both? Next, any surgeries within the last month. Again, you're going to have to take a look at this. This is subjective. What kind of surgery did the patient have? But that can also take them out of candidacy for thrombolytic therapy. This is a big one. Any history of intracranial hemorrhage. If the patient at any time during their entire life had an incident of intracranial hemorrhage, it is an absolute contraindication for fibrinolytic therapy. Next, does the patient have a history of bleeding disorders? Take a look at that. Next, pregnancy, and this is a relative contraindication, and we really have to evaluate the risk-benefit of administering fibrinolytic therapy to a pregnant patient. Next and last on the first part of the checklist, does this patient have any serious diseases that could complicate matters? So you want to get a complete history, medical history, complete sample history on this patient prior to administering fibrinolytic therapy. So let's look at step 1 of our fibrinolytic checklist, and this is concerned with the patient presentation. Is their presentation of chest pain been greater than 15 minutes but less than 12 hours. Now, when we're administering fibrinolytic therapy for embolic strokes, our efficacy window is about 3 hours. They're extending this out to 12 hours for AMI. So that's a big difference of the time frame between AMI and fibrinolytic therapy for embolic strokes. Step 2, look at your 12 lead. Is the 12 lead suggestive of a new AMI or a new left bundle branch block? We want to look at that 12 lead. Step 3 asked, did the patient meet any of the exclusion criteria from step 2? Now, right now with COVID, we really have to look at that carefully because we may not have an available cath lab. So you're really going to look for your absolute and relative contraindications for thrombolytic therapy. Lastly, we're looking for other conditions the patient might have. Are they tachycardic? Do they have signs of shock, heart failure, pulmonary edema? That may pull them out of candidacy for fibrinolytic therapy also. So this has been just a quick review of the fibrinolytic checklist for STEMI patients. I'm Mark. Thanks for watching. Be safe. I'll see you in the next video. Sir, on a scale from 1 to 10, 10 being the worst pain you've ever had, how would you describe your pain now? Where's that pain level at? I don't know, you know. How about this? Can you describe the pain to me? Is it sharp, dull, burning? Can you describe the pain? I don't know, you know, it's here. I don't know. Am I gonna die? I don't know.